So very good evening. I think without wasting much time, we'll move to the next session. I'm happy to sit here because on my left side is one younger brother, on my right side the speaker will come. He's another brother, so I'm happy between the two brothers. So the speaker is Dr. Vipul Chavda. He's a fellow of Royal College of Edinburgh. He's currently working as a chairman and founder at Rudrasha Institute of Medical Science. He's a treasurer of RSSD Gujarat chapter. He's a principal investigator for a lot of clinical trials, and he received the Bharat Chikitsa Puraskar.
Your brother is my main identity, and that's enough for the people.
He'll be talking about how to set up a diabetes clinic. Over to people.
So we are talking about setting up and growing up of diabetes clinic. At the offset, I would like to thank and congratulate Dr. Jyoti Dev sir, Sunita ma'am, and whole team of JPEF for a wonderful 13th conference. And I cannot start without thanking two important people of my life. Dr. Bansi Sabu sir, who is my teacher, my mentor, and not only my teacher and mentor, he is a teacher and mentor for many people across globe. And my colleague, my partner, Dr. Dhruvi Asnani, with whom we have started the journey of RIMS. So let's take a general scenario where we all are sitting in our OPD and our assistant or our receptionist come and tell us that, sir, you have 20 patients to see, you have 10 pharma people to meet, and you have one social event to attend in the evening. Is it a normal scenario or not? Yes? So my question to you is, are you running your clinic or your clinic is running to you? And this is the chaos. So this is my lecture to discuss about how we can convert a chaos doctor to a structurer or architecture of healthcare system. So let's start with this video.
सेठ जी
Do we have audio of this video?
सेठ जी आपको कुछ बताना है.
क्या बताना है?
मुझे कुछ पैसे चाहिए.
किस लिए?
कल रात को मेरी माँ बेहोश हो गई. मैं उसे हॉस्पिटल लेके गया, कॉर्पोरेशन हॉस्पिटल. तो उन्होंने बोला ऑपरेशन करना पड़ेगा.
हेलो हेलो, हाँ रेणुका, खाने में क्या भेजोगी? अरे नहीं, चपाती मत भेजना, चावल भेजना, चावल. हाँ ठीक है. हाँ उसे एक मिनट लाइन पे खड़ी रहे, लाइन पे रहे. हेलो, हाँ रामचंद्र जी, हाँ बोलिए. हाँ आपकी लिस्ट मिल गई है. मैं जरा ये चेक करके देखता हूँ दुकान में सामान है कि नहीं. हैं? लाइन पे रहिए, एक मिनट लाइन पे. गोपी, हाँ जरा ये चेक कर सामान है कि नहीं दुकान में. हैं? जल्दी कर, बता मुझे, बता. हाँ भाई, तेरी माँ
बेहोश हो गई, हॉस्पिटल लेके गया, ऑपरेशन करना पड़ेगा. उन्होंने बोला 5 बोतल खून चाहिए. तो ब्लड बैंक से 5 बोतल खून खरीद के जब वापस आया तो उन्होंने बोला 5,000 रुपए काउंटर पे भरने पड़ेंगे. तो 5,000 रुपए जब काउंटर
छोटे के लिए चाहिए, अपने वक्त बड़े के लिए.
अच्छा, छोटे के लिए नहीं है. हेलो, देखो छोटे के लिए नहीं है, बड़े के लिए चलेंगे.
So this kind of scenario are very common in our clinical practice. So let's understand what we need to do. In the India, we don't need more people who can generate more prescription, but we need a system that can cure or that can help to heal the diabetic patients. So first of all, why we should set up a diabetic clinic? Is there a need of diabetic clinic? Yes, there is a need of diabetic clinic because diabetes epidemic is exploding. Most of the physician or clinician who are attending the clinic, they are not structured care. In diabetes, we need a structured care, and that's why we are here. And we need a continuity of care. Only one-time consultation and prescribing medicine will not help diabetic population. And ultimately, I add on again my mentor's quote that we have to leave the diabetic people. We just need not to only treat the diabetic people. So how we can make a structured diabetes clinic? We have to have an individualized treatment, we have a diagnostic facility, we have a lifestyle advice, and we have preventive medicine, as well as we have to educate the people. If we are not making this structured care, we are not helping the people living with diabetes. Let me go through the journey of my own hospital, which is RIMS. Let me tell you, it was not born in boardroom. When me and Dr. Dhruvi started our diabetic clinic, it was a one-room clinic where only one glucometer, one stethoscope, and one BP instrument was there. But gradually, as the need arises, we develop a complete and comprehensive diabetic care clinic, and we solve the many problems that arise time on being. So today we will discuss the thing under this 6 agenda. First we will have 3-month action plan, how we can grow. We need to understand what, who, by when, and how format. But first of all, let's understand at what stage you are in your practice. Most of the clinicians, when they start, they are a manager of their clinic. And after 5 to 10 years, they became a leader. But they cannot go beyond the stage of leader and become entrepreneur and owner, and they just became a growth accelerator of their clinic. Understand, if you are the most important person of your clinic, then you are the bottleneck of your system, and if you are not there, your clinic will not work. So let's understand this 3-month action graph, where you have to understand that you are a mission commander and you are not just a doctor. What you have to do, first of all, you have to take a local diabetes survey. Make a Google form of 20 questions. If you are already having a clinic, then take your 20 patient survey, and if you are yet to make your diabetic clinic, go to a local community and meet 20 diabetic people and ask them about simple things, that are they satisfied with the current therapy, are they satisfied with the current service in your area, and if you are not knowing your patient, you are not running a clinic properly. Second is a SOP drafting. You can hire a consultant for your SOP, otherwise you can download from the template. See, SOP are very important. They are the blueprint of your clinic. If there is no written SOP, you will be always in chaos. Somebody will come and tell, कल मेरे चाचा के लड़के की शादी है मैं नहीं आऊँगा, and somebody will come and tell, मुझे तो ऐसा ही बताया गया था, and every time you are stuck in between many complex situations. Third is a staff hiring and HR setup. You need to have admin. Your receptionist or your educator can be admin in your system, but without hiring a HR or a staff policy, you cannot run a proper clinic. Today I will give you a 12 simple policy for HR that if you have in your clinic, your clinic will run very smoothly. Second is a patient flow optimization. Your educator or medical assistant will help. What you have to do, you have to make some flyers, you have to make some educational videos, and you have to circulate in the area surrounding you. Then comes a WhatsApp campaigning. Who will help? Your receptionist will help. She will every week send one video or one flyer to your patient, and pre-designed creativity will help your patient to keep in touch with you. Then workshop in OPD area. What you have to do? Call 50 patients per month. If you call 50 patients, then 20 will turn on in your clinic, and you have to educate them about the diagnosis of diabetes, complication of diabetes, what is important of monitoring, and it should not be a big event, but it should be an event which has big impact in the society. And last but not least is a review and adjustment. The whole team has to sit once a month. You have to review, you have to analyze, you have to find the error, you have to improvise that error, and then you can have a better system. So we cannot do everything at a one point. But if you are running your clinic, just identify one biggest hurdle that you are facing in your clinic right now. And every month try to solve only one problem. In a 1 year, you will solve all the major problem, and your clinic will be running like nothing before. So you have to identify who, where, how, what, when and why in your clinic. Second important thing is delegation. It was found in a survey that 80% of the people lost their time in the things that they are doing which they are not supposed to do. So first of all, in diabetic clinic is a HbA1c tracking. You need not to see all the HbA1c or all lab report. You can train your staff and train them to flag either red or orange or green. If the reports are okay, then the green color. If the reports need attention, then the yellow color. And if the reports need immediate attention, then red color. Your educator will screen all the reports, and you are proactive in your OPD rather than when the patient comes to you and then you see the report and then you react, oh, your HbA1c is 14 and we need to do something. This kind of reaction will decrease confidence of patient that you are not worried about their report, and you are seeing just when you are seeing the patient. Second is educational call. Your nurse is very important. She can call at least 5 people a day. And if you empower your nurse, your patient will be educated forever. Then social media. You cannot make a reel at 11:30 midnight and your family is waiting for dinner. You have to have a freelancer or some intern who can make a video for you and upload on social media. Supply and admin. You all have faced that thing that in the middle of the OPD somebody come and tell the glucometer strips are out of stock, the printer ink has been emptied, and you are the bottleneck of the system. Then you are seeing the patient or you are managing the ink of the printer. But you have to have one admin who will regularly check the stock and update you regularly. And last but not least is again a feedback. Your receptionist is your public relation officer. She is our first and last contact. So she must ask every patient that was the experience good or bad, if they require any call after they reach home or not, and then you can have a positive feedback from your patient. So here delegation is very important, because if you delegate the work, you can be free and you can focus on the work, what you have to do. But here how to is very important. How to is not just a decision, it's a skill. You have to decide whom to teach, and what to expect from that. Because without losing control is a bottom line. Because we as a doctor, we are always worried. Because we feel that somebody will make some mistake, somebody will misinterpret some report, or somebody will do some mistake that you have to answer. So you have to understand that you have to expect a simple thing from your staff, you have to educate them, train them over and over again, and then you can delegate the work. Then let's talk about HR policies. The 12 HR policies I have narrated here are extremely important. First and most important is leave policy. The day your staff joins your team, you just give him a role. But if you give HR policy, you give them a blueprint or roadmap what to do and how to do. So if there is no HR policy, then every month 5 people will come and tell, मेरे नाना बीमार है या मेरे चाचे की लड़की की शादी है, or whatever reason they can give you, they will give. Second is appraisal system. If you have a good staff and you want to retain them, you must have appraisal policy, because they are always worried about their growth in the system. Third is a ethics training. Your staff cannot share patients' HbA1c report on their social media. They have to have the confidentiality of the system. Then again confidentiality, that during the tea time they cannot talk about patient's disease condition, because we have to maintain the confidentiality, and there should be a written policy about confidentiality. Dress code. If your staff has dressed properly, it will increase confidence of the patient on the system. Code of conduct. Simple mistake can be forgiven or teachable, but misconduct must have consequences that your staff should know from the first day. Then grievance redressal. If your staff feel that they are heard properly, they will stay longer and they will fight less in the system or with you. Communication protocol is also very important. When to text, when to WhatsApp, and when to email, they should know. Disciplinary process is also very, very important, and exit interview are very important. If somebody is leaving because of some reason, then also you have to have exit interview to know what you can improvise in your system. So in India, we mostly believe in this kundli. So if you have a very much attrition of staff, then you say अपने तो केतु की दशा चल रही है, अपने स्टाफ यहाँ नहीं टिकेंगे. But ऐसा नहीं है. If you have a proper HR policy, if you implement it properly, then you cannot depend on your kundli, and you can have SOP that will help you to work more. So with the time constraint, I will move some faster. Then most important is reporting structure. We cannot rely on chaos. We have to have the reporting system. We need not to have drama. We have to have dashboard. Every week you have to sit with your staff and you have to discuss about how many follow-up patients have came, how many educational call has been done, what are the HbA1c that require immediate attention, and what are the patient who has a foot problem or fundus problem. Then and then you can have a proper system to work. Then technology. Now technology is not something that you need to have. It is must in your system. If you are not using technology, then your clinic is like a clinic without electricity. You have to have many systems. Then diabetes is also one disease with many angles. What you have to do, they have been mentioned over here. First is information and aspiration. Diabetes is not just about sugar. It's about mood, it's about food, it's about relationship, it's about energy, it's about confidence of the patient. So you must have some training session and some information session for your patient. Then camps and community. Diabetes is very isolating disease. When patients have diabetes, they feel so much isolated. So you have to have some community event. You can have some movie night. You can have some cooking classes to engage your patients. Then fundraising is also important when you are running a clinic, because you have to have fund to do some activities regularly. Then mental illness is also very important. Mental well-being is not luxury. It's a necessary and basic need for diabetic people. Clinical care, I am not going in detail in clinical care because you all know how to manage, but I must say that you have to offer your patients the latest medicine and latest technology like CGM and closed loop pump to your patients. So diabetes is a one disease, but it has a many angles. You have to have patient-centered approach. You have to have a dietitian, physiotherapist, diabetic nurse, and a psychologist in your team, and treat the person, not just the sugar, is the bottom line of the thing. And last but not least is a marketing thing. Be smart and be seen. Set the right pricing according to your area. Host various seminars in your vicinity and build credibility before profit. How you can market? You can have a local visibility, OPD, health talks, poster in nearby laboratory or pharmacy, and WhatsApp updates. You can have digital presence by a Google platform, on social media like Instagram and Facebook. A doctor branding, attend many CMEs and give some talks in CMEs. Referral network, you can use a nearby GPs, specialists, dietitian and pharmacist group, and also community engagement program like on World Obesity Day or World Diabetes Day. So in the end, I would say that you have to take the first step today. You don't have to only prescribe one medicine, but you have to develop one system that will help diabetic patient to live better. So start with purpose, not with panic. Think about system, not just symptoms. Delegate and be free to grow. Structure brings sustainability, and you don't need to be bigger, but you have to be better in your working pattern. Start small, stay consistent, and scale with intention to provide better care. Because diabetes may be common, but better diabetic care facility are not very common. With that, I would thank you all for silent listening.
Thank you, Vipul, for that inspiring talk, especially for the juniors sitting over here, and how to start, scale up, and how to make work-life balance, delegation, a lot of practical points from this session. And as we are running short of time, so we'll take one or two questions. I think the most inspired one will be Dr. Ashwin, who is going to start one clinic next month. You will be having some queries, I think.
Excellent talk, sir. Yeah, you have, I think you have put it all in the slides and enlightened us in 10 to 15 minutes of time. That bottleneck, the delegation, all those key words has to be the take-home messages for doctors like us who are planning to set up our own diabetes clinics. So for my question to you will be like, what made you think that you have to start on your own in the first place?
See, when I was only physician, I was treating from fever to fracture, from trauma to tension, headache, but I was seeing so many diabetic patients. They are mainly undiagnosed. They are meeting doctors for UTI, for fevers or for cough, but they have been not done RBS. Though we are telling RBS will be first, fifth vital, but most of the time in periphery they don't check sugar. Second is diabetes is undertreated. Though the patient is diabetic since 5 to 10 years, still their HbA1c is 9, 10 and 12. So they are just prescribing medicine, they are not educating, they are not motivating, they are not engaging them in a manner that patient will continue the therapy. And that's why I was attracted toward diabetes, that something structured care is required in this field, and then we can contribute something to our country.
Thank you, sir.